Okay, welcome to this side event of the 53rd session of the UN Statistical Commission entitled Measuring the Impact of COVID-19 on Mortality. How can surveys and censuses help? I'm Francesca Perucci, Assistant Director at the UN Statistics Division, and it is my great pleasure to moderate the event today. It has been already over 2 years since the beginning of the COVID-19 pandemic, which has had a dramatic impact on people's lives. And one of the biggest challenges in addressing and mitigating the impact of the pandemic and designing the appropriate measures and interventions has been obtaining the necessary data. It's been particularly important and challenging to obtain data on the number of lives lost due to COVID-19, including not only the ones directly resulting from the disease itself, but also those that are due to the pandemic, lockdown, other measures, and the overall impact of the pandemic on society. One way to estimate that number, which we refer to as excess deaths, would be to compare the number of deaths during a specific period during the COVID pandemic with an historical baseline pre-COVID pandemic, using data from CV registration and vital statistical systems, where those offer sufficient coverage. But this is, of course, not the case in the many countries without a good CRBS system. According to the latest information we have, only 62% of the countries in the world have death registration data that are at least 75% complete. So this proportion is only 17% for countries in sub-Saharan Africa. So given the challenges in obtaining accurate mortality data, the UN Department of Economic and Social Affairs and the World Health Organization, WHO, have joined hands and established a technical advisory group, TAG, on the COVID-19 mortality assessment that includes experts from national statistical offices and relevant ministries, academia, and other regional and international organizations. So within the technical advisory group, there is one working group in particular that was established to provide recommendations to national statistical offices on innovative methods to collect time-sensitive and reliable data through censuses and surveys that can be used to measure the excess mortality associated with the COVID-19 pandemic. So the event today, which is jointly organized by the UN Statistics Division and the UN Population Division, the two divisions in the department that have been servicing this process and working with the working group. The event will provide the opportunity to review the work of the group and also other experts. The recommendations of the working group are intended to provide the tools to help fill the data gaps in adult mortality estimation in the context of COVID-19, and also to build a more agile and resilient statistical system in preparation for future possible crises, including pandemics or natural disasters, etc. And as we approach now the 53rd session of the formal session of the Statistical Commission in early March, it is particularly critical that we bring these results to the Commission. In this regard, I would like to point your attention to a draft stock-taking paper by the working group, which is made available to the Commission as a background document so that it can be reviewed and we can obtain further inputs and comments. And I hope the link is being shared in the chat for that document so that you have access to it without having to look for it and navigate the website of the Statistical Commission. This is still very much a work in progress, which I'm sure will benefit from inputs from the global statistical community and other experts that can provide further comments. And then a further developed document will be shared for further consultation. So today we have 5 great presentations by colleagues joining us from national statistical offices, research institutions, and 1 regional commission. Who will be talking about the needs for and challenges in obtaining mortality data from censuses and surveys, existing methods, data collection, innovative approaches, etc. And then we'll open the floor for questions from the audience. Just allow me to remind you to keep yourself muted. I think we know that well by now. When you're not speaking, keep the video off if you can when you're not speaking so that we save bandwidth. And please do let us know what you think in the chat and give us inputs, share your questions. Also know that the session is recorded and is also being streamed live on YouTube. And again, I hope that the links will be shared soon on the chat. And then the link to the session will be shared after the event. So let's start and get to our great speakers. The first one is Mr. Stefan Helleringer from, he's a professor of social research and public policy at NYU, New York University in Abu Dhabi, also chair of Working Group 2, the working group that I just mentioned. Stefan will report on the work of the working group on current data sources on adult mortality, discuss emerging recommendations and innovations in using censuses surveys for adult mortality data collection. Stefan, over to you.
Thank you, Francesca, and thank you everyone for attending this session. So, as Francesca mentioned, I've had the pleasure of chairing this working group on the use of surveys and censuses to fill adult mortality data gaps as they pertain to our assessment of the pandemic. And so I'm going to give a brief overview of the data sources, the data collection methods, how they are challenged by the pandemics, and how we might, modify them or make them evolve a little bit to try and strengthen our assessments of adult mortality and excess adult mortality during the pandemic. If I could have the next slide. Okay, next, some more. Thank you. So in terms of data, the pre-pandemic landscape is well known and has been described already by Francesca. And the key problem is that many, I think, low and middle income countries lack sufficiently complete civil registration systems to track excess mortality from a crisis like a pandemic in real time. And instead, in many low and middle income countries, data on mortality levels and trends are collected periodically during household surveys and decennial censuses. And so these traditionally fill the data gaps that are left by CRVS systems. But so what we want to address in this working group is how they might keep doing that during a pandemic. Next slide. So how do we collect data on adult mortality during surveys and censuses? Well, typically there are three general methods that might be used. The first one consists of eliciting data on recent household deaths. Typically, this takes the form of the questionnaire you see on the right of the screen here, where we ask a household head or another household informant to list all the deaths that have occurred in the household over a recent period of time, usually 12 months. And for each death, we ask about the age at death and possibly the date of death, and sometimes also the circumstances of death. For example, if it occurred during pregnancy for women of reproductive ages. Okay, next slide. Data on adult mortality can also come from questions we might ask about orphanhood. So for, again, here in a census or in a household roster, we might include a couple of questions about certain household members, asking whether the biological mother or the biological father of a household member is still alive, yes or no, or don't know. And this, together with some indirect methods of estimation, might generate some estimate of adult mortality rates. Very often, those questions about orphanhood are only asked about parents of household members who are 0 to 14-year-olds or 0 to 17-year-olds, for example. In some censuses, like in the recent Ghana census, for example, they might be asked about all the household members, regardless of age. Next slide. And finally, one data source that's often collected in surveys in particular consists of asking questions about sibling survival. And so that's typically the maternal mortality module of the demographic and health surveys, for example, but it's also increasingly included in surveys like the mix. And so these data collect a list of all the siblings of a respondent, and for each sibling, they ask whether they are still alive, and if so, at how old they are. And if they are no longer alive, they ask how old they were when they died and how many years ago they died. And so with this type of data, we can directly estimate key indicators of adult mortality like 35Q15 or 45Q15. And so on and so forth. And in many low and middle income countries, these might be the primary source of data we have on adult mortality and the most frequent one. Next slide. Now, how does the pandemic come into play in this data landscape? Next slide. So, first of all, safe to say that the data gaps remain in CRVS. They are possibly exacerbated by COVID-related restrictions that prevent people from registering a death, going to a registration office, fear and stigma that might limit the use of some of those offices and services. The epidemiological surveillance system that monitor COVID-related deaths, in particular, the typical numbers that are reported maybe by ministries of health or public health agencies are also incomplete in monitoring the impact of the epidemic on mortality, because there's limited testing for SARS-CoV-2 in many low and middle income countries. And also because by definition, these epidemiological surveillance system only count the COVID deaths. They do not look at the indirect effects of the pandemic on mortality. For example, what might happen when people cannot access certain healthcare services, or when there are economic downturns and there are issues with economic livelihoods. Finally, it's been recommended to establish rapid mortality surveillance systems, for example, through the surveillance of burial sites or morgues or cemeteries. But these so far have only been established in selected cities or areas in particular. Next slide. So what is the role that surveys and censuses can play? Well, it's a bit of a difficult role, because at least in the first couple of years of the pandemic, censuses and household survey were often postponed themselves or canceled due to some of the health risks they might pose because of collection of data in person and the concerns that the COVID-19 might spread during interviews or during trainings and so on and so forth. But also there are issues because questionnaires and methodology are not necessarily adapted to measuring recent excess mortalities. So, for example, some of the limitations we've highlighted in our work on the working group might have to do with reference periods that might be too short, or the age groups that are affected are those that are imperfectly covered by the data sources that we have. In particular, I'm thinking about older age groups. For some surveys, sample sizes might be too limited, especially to detect recent changes in mortality in recent years. And there might be also clustering of mortality in households and families, because COVID-19 is spread by respiratory droplets. And so people within household might get sick and so on and so forth. And there might be some selection biases here. Next slide. So here, this working group is part of the broader technical advisory group on COVID-19 mortality, and it's one of several working groups working on specific aspects of strengthening the inferences and what we know about the impact of the pandemic on mortality. Next slide. And so, what are some of the emerging recommendations that might have come, that might have cropped up from our discussions and our work as a working group? So, next slide. Yeah, so in terms of censuses, one thing that has consistently come is the potential utility of expanding the recall period for household deaths. So right now, the recommendation is to use 12 months, but of course, in many countries, this does not cover the entirety of the pandemic, and it does not even include some potential pre-pandemic period that might be helpful in estimating excess mortality. So here, one thing we've discussed extensively is whether it might make sense to expand the recall period to 36 months or something that would encompass the entire pandemic. Another aspect that we're discussing and that seems to emerge as a recommendation also is to collect more detailed data on dates of death. Many censuses only collect data on whether the death occurred within the past 12 months without any further detail, whereas statistical models of excess mortality very often require the month of death to infer the presence of excess mortality. So collecting this would be extremely helpful. And third would be to expand the data collection on parental survival in two ways. One would be to collect the age at death and the dates of death of the reported parental deaths, so that we can allow direct estimates of mortality, in particular at the oldest ages. So that we don't need to revert to indirect method that might be uncertain and that might place our estimates in distant time points prior to data collection. Next slide. Before, I think you're missing a slide. Yeah, in surveys, similar recommendations are emerging about how to modify survey instruments, but additional consideration pertain to sampling approaches and sample sizes. I think a lot of the current sample sizes used in surveys are designed with objectives to measure adult mortality in relatively long periods of time of 6 to 8 years prior to a survey. Whereas in trying to estimate excess mortality during the pandemic, we are really focused on the most recent time period. So powering surveys to detect such recent changes in mortality seems particularly important. And then the potential also to consider nested follow-up studies that would collect, for example, verbal or social autopsies that would allow more precisely characterizing causes of death or circumstances of death or care seeking prior to death would be extremely helpful in that context as well. Next slide. So one other aspect that seems to cut across data sources on excess mortality would be also to include direct questions about the status of reported deaths in CRVS, so that we can evaluate how complete CRVS recording of deaths might have been in recent time periods, including during the pandemic. And that this might be later used to adjust mortality rate that can be estimated from CRVS data, or to triangulate data sources that are available. Such data have been collected in previous study. Here's a study in MATLAB recently that in Bangladesh that collected this, and you see that it helps pinpoint, for example, big gender gaps in registration of deaths in the area. Next slide. So finally, as part of this working group, we're also considering what might be some perspective and new opportunities to collect survey data and census and strengthen census data in different ways. So beyond this initial set of recommendations that would target the short term and the immediately upcoming censuses and surveys. So this pertain to new questionnaires, for example, collecting data on networks as some presentations in this session will cover. some new modes of data collections, for example, from through mobile phones, or other data sources in which surveys might be administered or might be combined with survey data. So, for example, web sources or data from social media. Okay, so here on the right, for example, you have initial results from trial of collection of mortality data by mobile phone through the RAMPS project supported by the Gates Foundation and UNICEF, where it shows that it is in fact feasible to collect such data, and just as feasible as it is to collect data on socioeconomic condition and variables, for example. So in summary, this is where this is the state of our current discussions in the working group, and we'll keep refining this and producing documentations of all these recommendations that I hope will be helpful for future work and upcoming surveys and censuses. Thank you.
Thank you so much, Stefan, and great presentation, great overview. And now let's turn to the experience of Bangladesh, and let me remind everybody to please stay within the 10 minutes. We have a lot of presentation to go through. The presentation from Bangladesh will be jointly made by Mr. Alamgir Hossain, who's the Deputy Director and SDG focal point in the Bangladesh Bureau of Statistics, Mr. Shams El Arifin, Mr. Ahmed Rahman, and Ms. Amica Hossain from the International Center for Diarrheal Disease Research in Bangladesh. And they will be presenting the adult mortality data collections in Bangladesh. Over to you. You have the floor. Thank you.
Let's take first. Do please confirm that you can see the presentation also present. Hello?
It's all good. Thank you. We can hear you and the slides are good.
I can see that subtitles are coming. Let me start that one.
Okay.
Okay. I would like to share about the current situation of Bangladesh and how the mortality indicators are being estimated here in Bangladesh through the sample vital registration system by Bangladesh Bureau of Statistics. Before starting the presentation, I would like to sorry. Okay. Okay. So, you already know that in Bangladesh, we are at the initial stage for setting up the civil registration and vital statistics system. Our cabinet division is working on it along with the other relevant department in the national statistical system and local government. We have a separate statistics, as well as the Birth and Death Registration Act 2004, under which the birth and death registration are conducted by the local government, as well as the our foreign missions through the authority, Birth and Death Registration Authority here in Bangladesh. And Bangladesh Bureau of Statistics is actually mandated to generate the official statistics from the different sources. Either they are conventional survey census, or they may be from the secondary data from the different administrative sources. So in Bangladesh, currently the vital statistics for Bangladesh are produced by the BDS through the vital statistical system, sample vital registration system. especially for in between the two particular population and housing censuses. Now, so under this sample vital registration system, actually, it is likely a registration system which are conducted on sample basis, and it was introduced in the National Statistical System in 1980 to estimate the different demographic indicators during the intercensal periods. Our objective of this particular SDRS is to ensure the data from the sampling area for the particularly different vital events, so that we can generate data for the demographic events in following the Chandrasekhar and Daily method, that is the dual method we are following from the 1980s. Our currently under this particular registration system, we have 212 primary sampling units. Within each of the primary sampling units have around 150 households. Currently, according to the last year report, we have about 301,000 sampling household in the sample vital registration system. And we have recruited a local female register to record all the vital events in the particular PSU area. Under this system, we actually cover the birth, death, in-migration, out-migration, marriage, divorce, contraceptive use, disability status, even the HIV/AIDS related information, along with the other household and individual level socio-demographic data under this particular sample vital registration system. I already mentioned about that. We have appointed the local female registers who are actually visits the sample households in the particular primary sampling unit area with the structured questionnaire, and they are being supervised by the local PBS officials to ensure the quality of the data. If I particularly mentioned about the date schedule of the survey or registration system, the registration system actually contains about 8 particular questions given to the deceased person. If we particularly the age, sex, date of the deceased person, then the cause of death, and the registration issues, and also we try to identify the particular cause for the maternal mortality issues. And finally, when they filled up the questionnaire, and in every month they send the hard copy of the particular schedules, filled up schedules to BBS headquarters to compile them centrally. I have shared here the specific death rate from the sample vital registration system by residents here. You can see here that the death rate per thousand here in Bangladesh is, I have shown here from 2015 to 2020, and you can see here the neonatal death rate, and the adult death is being growing. If we see that actually the rate is being growing after 40, but here in Bangladesh we consider 60 years and above as adult death. And in the recent years, particularly in 2020, you can see that the rate of the death for the adult who are more than 18 plus, they are slightly decreased than the previous period. Here I have tried to show few of the major causes according to the causes of death according to the SBR system, particularly for the 60 plus of adult deceased persons. You can see here that some of the causes which are actually highly prevalent than the COVID-19 in 2020. In 2020, we have identified that the death rate per thousand was 0.05. But among the other causes, though we are collecting about 100 major causes of death, and currently we are not following the ICD-10 for the classification of the death, and identified that COVID-19 death is lower than the other causes of death, particularly different non-communicable diseases. To introduce the ICD-10, we have tried to pilot a verbal autopsy here in Bangladesh so that we can address those particular methods in our sample vital registration system in future. I will share some issues later. So here I have tried to share the COVID-19 deaths per thousand population which have captured under the sample vital registration system. We have also identified that if we see the age group, the higher age groups are more exposed to the COVID deaths, and we have identified the area where the subnational level and designated level. We have seen that the Dhaka is the leading subnational area where the death is very high, and the other dimensions have been also seen here. The urban area by the locality is leading, and male population is more exposed to the COVID death than in terms of their sex. And if we see here the particular and very interesting statistics here in 2020, according to the Director General of Health Services, the total death was due to the COVID 7,559, and according to our sample vital registration system, we have estimated it was 8,110. It is very usual because the sample vital registration system identified those deaths after a certain period of time. But for the administrative data, all deaths are actually not caused in the hospital system, and death at their dwellings are not properly reported every time in the DZ health system. So whenever we are visiting in those households of the deceased persons, and our data collectors are from the same community, so they are very aware of their death, and they have interviewed their family members, identified some few causes, about 7% extra deaths, which are causes under COVID-19. Okay. You can see here the COVID-19 death. I have tried to compare the SBR system and the DZL, the administrative system data. You can see here the deeper proportion shows the sample vital registration system, and the DZ health data in the lighter blue color. If you see here for the particular region of Dhaka, the DZ health data shows a higher number or higher proportion of death than the SBR system. It is very interesting that during the COVID, in the subnational level, the facility for the COVID-19 treatment is not enough sometimes, and they refers the critical patients to the different tertiary level hospitals in Dhaka, so that the number of deaths caused in the hospital or facility is very higher. But whenever we visiting the household, that are being lower compared to the other compared to the administrative data. It is a very interesting one if you see that. Another interesting thing I would like to share here, if you see in terms of the sex, you can see here that in the administrative system, female are less reported than the male. So it should be an interesting one that in the administrative system, maybe the sex of the deceased person are not properly reported sometimes, or maybe they are somehow underreported, maybe in the SBRS system or maybe in the administrative data system. So it is one of the interesting system. I have mentioned earlier that we have piloted the herbal autopsy recently by BBS in the last year in June. We have actually used the stepwise plausibility analysis and software tool that was created by the University of Melbourne to analyze the plausibility of the outcomes of about 310 herbal autopsies we have captured from the field level through the herbal autopsy survey. And we have utilized those new data to identify the primary cause of death in the community fatalities, and randomly selected 50 pieces across the Bangladesh from where the data were collected. So
I'm sorry, Alamir, sorry to interrupt you. You're really out of time. If you can, perhaps your presentation will be shared, maybe get to the key points. Thank you so much.
Thank you. I am almost at the end. So I will share that particular slides with you, and I hope in the near future we are trying to address this verbal autopsy in our sample data registration system to address the cause of death according to ICD-10. Thank you for patience hearing. Thank you.
Thank you. And I'm not sure if your other colleagues will come in at this point. Amica?
Can you see my screen?
And just let me remind you that we only have 10 minutes allocated for the two interventions.
Yes.
So thank you.
I will try to keep it short and quick. So I'm going to present our studies conducted in ICDRB to assess the excess mortality, and we tried to measure the impact of COVID-19. These studies, what we conducted in our team, have been led by Ahmed Ehsanur Rahman and Dr. Shamsana Arifin. I'm presenting on behalf of them. And I would also like to acknowledge Ms. Samantha Dolan from Bill and Melinda Gates Foundation for her technical assistance throughout these studies. Just a bit of context regarding the Bangladesh situation on COVID. So we can see that we have so far observed around 2 million cases of COVID-19, and the death toll is very high as well. So it is more than 28,000. So you can see there are spikes at different time points, and currently we are observing another spike in Bangladesh, but the death toll is not that high due to Omicron. But our studies actually looked the COVID-19 impact during 2020 mostly, and we are collecting data for 2021, and we hope to present the analysis as we go along with the studies. So as we already know, some of the challenges like other low and middle income countries, Bangladesh also has low coverage of CRVS, and we do not have good cause of deaths data, and most of the deaths occur in home where we cannot attribute them whether they're due to COVID or not, and also we don't know the indirect effects of COVID. So to respond well to an epidemic, we need to know the epidemic. So at this moment, we felt that we do not have a very good data system which can inform the policymakers to take quick and effective decisions. So with that motivation, we in ICT-DRB, we started thinking of some innovative and inexpensive ways to report on excess mortality. So one of those was using demographic and surveillance sites data, and the second one was the household survey data at a subnational level, and the third one was data extracted from burial grounds. So firstly, a little bit of methodology on the demographic surveillance site data. It has been published, this study was led by Dr. Hanifi and colleagues. The study entitled Insights into Excess Mortality During the First Months of the COVID-19 Pandemic from a Rural Demographic Surveillance Site in Bangladesh. So they basically compared the historical data from 2015 to 2020. So they reported the excess mortality taking the trend of from 2015 to 2019 and compared that with 2020, and then they did some time to event data. So a snapshot of the overall excess mortality is they have reported 28% excess mortality in 2020, and they have taken data from the first quarter. So they have used the data from January to April, and you can see that at the elderly population, 65 plus year old, you can see a hip here on the excess mortality. So in 2019, 80 per thousand life per thousand population, and in 2020 it's 110, so 30 per thousand population more. And then moving forward to our study, that is a household survey at the subnational level, which is in a sub-district, Sitakundo. It's in the southern part of Bangladesh. So you can see the map here. So, and the place site is at this part. Firstly, we did a village mapping of our selected clusters, and our clusters consisted of 300 to 500 households, which translated into 1,500 to 2,500 populations. And then we did we collected data from those selected households. We did a member listing using some basic demographic variables, and also we collected information on the deceased people for last 3 years. Whoever died in last 3 years, who were a member of that household, we took information for them. And we throughout the study we did the quality control mechanism, and we conducted social inquiry model to improve the data quality and to prevent the underreporting of deaths. And finally, with all the identified deaths, we conducted a verbal autopsy, and we used algorithms to assign causes. But we're still analyzing that data, and we're trying to understand the best way to report on the causes of death. So primarily, we use the P-score as a measure of excess mortality, which is basically comparing the average deaths of 2018 and 19 with the excess number of 2020. So this is the finding from household survey, and this has not been widely shared yet in Bangladesh. So we are still trying to figure out an optimum, a robust way to interpret this data. So for sure, we are observing some level of excess mortality in the population of age greater than 40. And there are some hips here as well at the lower age group, but we don't know what happened here, but we are figuring out the best way to interpret that. Our other approaches include survival analysis and time series analysis. These are ongoing analysis, and we would, with time, we would report on these data as well. So one snapshot from Cox proportional hazard model using time to event data for the deceased people more than 40 years. So we can see that we have a 1.5 times higher hazard ratio for 2020 compared with 2018 and 19, and for male it's the hazard ratio is higher. We did not find any significant hazard for religion groups or wealth. For education it's significantly higher, and for age it's obviously significantly higher. And our final method was from the burial grounds records. So we have extracted burial records from 6 public graveyards under Dhaka North City Corporation. So in Dhaka, we have 2 big city corporations, Dhaka South and Dhaka North. So there are 6, yes. So there are 6 public graveyards under DNCC, and we have extracted records from there. And we tried to report on the excess mortality across the graveyards, and we acknowledge the heterogeneity across these graveyards. So we are having some interpretation issues here, because in all the graveyards we are observing different P scores, different level of excess mortality. And in this particular graveyard, Rayar Bazar, we are observing a bit of high mortality because it was COVID dedicated from the beginning of the COVID pandemic. So we tried to exclude the data from Rayar Bazar while reporting on the P scores.
We just lose the sound from Anika.
We can't hear you, Anika. We lost the sound.
Anika, we can't hear you.
I suggest that
People only. Yes, that's
yeah,
the end.
and that's the end. Okay, thank
Yes.
you. And sorry, we lost the last bit of your audio, but I suggest that everybody goes and checks reads the PowerPoint. Thank you so much, Anika. That was incredibly interesting. And I'd like now to turn to the experience of Malawi. And for that, I'd like to give the floor to Richard Pires, Principal Statistician in the National Statistical Office of Malawi, who will present the mortality data collection estimation in his country. Over to you, Richard.
Hi, Richard. We cannot hear you. Would you like to unmute yourself? Oh, Ishi, can we unmute Richard? He just joined again. That should be okay. Okay.
Yes. Yeah, thank you, Francisca. And everyone, can you hear me?
Yes. Yes.
Okay. Okay, thank you so much. I have a quick presentation on the experience of Malawi in terms of mortality data collection and estimation in Malawi. I'll go straight into my presentation. I'll start with the outline of what is it that I'm present. I'll just give a short background of the mortality estimation in Malawi, census undertaking, household surveys, and I'll finish with CRVS and future plans. Next slide. In terms of introduction, actually, for countries in or any geographical domain of interest, the changes is linked with birth and death and migration. So these have been widely documented to vary, and really their magnitudes have also different interpretations and impacts, which can you move? Which necessitates the need to have a better understanding of them. The researchers mentioned, as we all know, the mortality is linked to socioeconomic development, quality of life, incident, and also standard of living, things like those. So just trying to actually necessitate the need why we need to emphasize on the understanding how and actually estimating mortality in the country. Can you move next? Yeah. So as other presenters have indicated, the measurement of mortality actually is dependent on the quality of the data that we have and also the level of detail. So which we either can use direct or indirect estimation approaches. Can you move next? So in Malawi, I think I'll start with the census undertaking. Next, please. So in Malawi, census date back to as late as 1966. That's because there were other censuses prior to that one, but they were not that comprehensive. So we don't we can't get much from them. But from the 1966 moving forward onwards, I think those are the ones which we rely on. So these are just they are meant to provide input for planning, monitoring, and also evaluation of national and international development initiatives. So we put extra effort to make sure that the data which you collect through the census is it's comparable, both the local and internationally. Can you move to the next slide, please? So with that understanding that we would want to have the data that should be comparable, and also so that we should have reliable estimates, the census undertaking is mostly guided by the UN principles and recommendations, and which focus on the universality, simultaneity, and other things. So we try as much as possible so that the data which we collect from the census is reliable. I think maybe let me just highlight that like other presenters have indicated, the CRVS in Malawi is still new, actually, the system. So there's been high reliance on the census and surveys. So that's why we try as much as possible so that we should have quality data from the census so that we can come with the estimates on mortality. Next slide. So as you're all aware, we collect a number of attributes in the census, the age, the sex, and all that. But in respect of mortality, we collect the number of deaths which have happened in the households, for those deaths which have been reported, we also want to understand the age, the sex, and the place of residency. And the other thing which you would also interested in is the cause of death. What led to the death, so that we can make the right estimation. And one other thing which I should also highlight is that in Malawi we did the last census in 2018. By then we never had the pandemic wasn't the COVID-19 actually wasn't at that time we didn't think of collecting the data around COVID-19 in the census because I think because of the timing of the census. So in the census actually we just looked at the name of the deceased, in which month they died, and the year as well, and the sex, and we went further to look at the age. And as indicated on M06, we wanted to understand what caused the death. What caused the death? Is it due to accident, injury, or violence? For women, we go further to look at whether the death is related to is it maternal? That is whether the deceased died when she was pregnant, or during childbirth, and further whether it was within 2 months of termination of pregnancy. So this is the module which we administer during the census. And can you move on? So from this we try to process the data. Like you are all aware, the errors tend to vary. So our data processing is responsive in nature, so that we go through the data to understand what is there, and in response to what is there, we do data processing. So there's great effort in terms to minimize and possibly get rid of errors. We also, considering that there's knowledge and skills on data processing and also analyzing the data, it's continuously changing. There's more effort in terms of building capacity of the technical team. We try to do, we organize international and local short-term trainings. And also we collaborate with experts from the University of Malawi, the US Census Bureau, and UNICEF, just to mention a few, so that we try to get more, to get the skills and the knowledge which would enable us to estimate mortality from the census. We also do some desk and online review, online reviews, literature reviews, so that we should also enhance our knowledge and skills. And from the basing on the applicable, basing on the data which we have, and also the level of data that we have, we decide whether we should do direct estimation or indirect estimation of mortality from the data which we collected, so that we can be able to estimate the levels and also trend of mortality in the country. Next slide. And as we are aware, our census we do every 10 years. To complement that one, we also do household surveys. These surveys are done during the intercensal period, just to complement the census data. Recently, there are a number of surveys have been commissioned, and to say the truth, actually, the surveys which have implemented in recent years have been greatly affected by the COVID-19 pandemic. Actually, the issue of travel restrictions, social distancing, we couldn't do some surveys which I think actually could have given us an opportunity to understand the impact of COVID-19 out there. We have tried to do a welfare survey, which was done through mobile phones. However, because of the sensitivity of issue of death, we advised not to include the questions around death, because we would, as ethically, we couldn't provide the proper platform for asking those sensitive questions. So we basically focused on the welfare of household, which we feel that to a certain extent is linked to the impact of COVID-19, and also. So as for face-to-face household surveys, we have done the DHS and the multiple indicator cluster surveys. Equally, during the development of the surveys, the COVID-19 had the impact wasn't that much, so we didn't have specific questions around COVID-19. We just looked at some of the areas in the census, and so that we could estimate fertility, mortality, and other statistics, and also do some trend analysis. Moving on to the same household surveys, actually, in terms of technical implementation, we try to use international standards, so that the results are comparable, and also we could easily duplicate if need be. We do consultative meetings and propose the on the modules which we plan to administer during the service, and also do some user needs assessment, because in Malawi, yes, much as NSO has got the mandate to produce official statistics, there are also other data users or the other data producers who also benefit from the data which we collect. So, and the issue of COVID-19 itself, there's high demand for data on COVID, but unfortunately, because of the situation that we're in, we cannot collect data from the surveys which we have done recently. Moving on to the next slide, which is just trying to ask to understand what is it that we collect in terms of mortality, and also on the what to understand
I'm sorry, Richard, to interrupt you. You're really out of time. If you could perhaps highlight the key points and
I'm winding up.
Thank you so much.
I'm winding up. Next slide. Next, so these are just some of the questions. So on the CRVS Malawi, actually, like it was as indicated, the CRVS in Malawi is not fully fledged. The system is still in its infancy. Then the data is not reliable. It's still not complete. So we at the moment we are still trying to put together the system so that we should be able to get more comprehensive data for modality analysis and also to understand even the impact of COVID-19. Just to provide more information around the CRVS, like I said, it's still new. We are trying to put in place a system. As of 2017, we initiated the registration of death and then cause of death. This is using medical certification of cause of death. And the data collection is also taking, it's just taking place in 17 out of the 32 districts. And to complement this one, they've also introduced the committed registration of deaths, which is just to provide more information to the data which is being registered at the hospitals. So this currently we have 14 out of 32. And the plan is that we should be sharing data between NSO and the NRB so that we could, in addition to the data which we collect as NSO, we should also have data from NRB, which is collecting the information on deaths and cause of death. Like I said, because the system is still new, there's low confidence because of the issue of representativeness and coverage. And we are planning to start sharing the data once they do reach 80% of the districts. Next slide, and the final one, I guess. So the future plans, what we're planning to do is that because there'll be data coming from the National Registration Bureau, we would want to have we would not be conducting validation of mortality data and estimates. What we're planning to do is that we want to have more detailed information from the surveys and censuses, so that we should be able to match with the data which is being reported in the system. The plan is that we plan to use the data, the CRVS as a reference for assessing mortality and also evaluating reliability and of the mortality indicators. That whether there's in the actual to quantify the difference between what is being reported in the CRVS system and also what the surveys are capturing. I think basically that's what I can say about the experience of Malawi in terms of mortality estimation. Thank you.
Thank you so much, Richard, for the rich presentation. And let me now turn to our speaker from Dennis Fayan, Assistant Professor of Demography at the University of California, Berkeley, who will present the use of sample social network data to estimate adult mortality rates. Dennis, over to you. Thank you.
Thank you very much. So let me just share my screen. I apologize. Great. I'm sorry, I'm having a little bit of trouble sharing my screen.
Can we offer from our side? We've tested, it should work.
Great. Okay, sure.
Yes.
Thank you.
Yushi, do you mind share the video?
Share the video? Okay.
Or if you give me the share rights, I can do it from my side.
Can you see this video?
We can see the video. Try play and see whether I can hear it.
Can you hear it?
No, it's in the background. So when you share, there's a button you have to unclick, make sure, because right now it's from your speaker, I think.
Okay, let me try that again.
Thank you very much for inviting me to join you today. I'm going to be talking briefly about using sampled social network data to estimate adult death rates. So I thought I'd start by just sort of outlining what I think are the two big challenges to measuring adult mortality on a survey. So the first one is that we're used to conducting surveys where we can sample people and ask them to tell us about themselves. So we might ask them, whether or not they're married, how many children they have, that kind of thing. Obviously, in the case of deaths, we can't do that. We can't sample dead people and interview them. So that's a challenge. We have to find some way to learn about dead people from people who are still alive. And then the second challenge is that even in places where mortality is pretty high, adult deaths are still pretty rare events, statistically speaking, which means that a lot of approaches that come to mind are going to require very big sample sizes to produce precise estimates. And the leading approach to overcoming these challenges right now is something called the Sibling method, which I think you have probably discussed. So I'll just kind of quickly recap, but I'm not going to talk too much about it. But the big picture idea here is to ask respondents to list their siblings, when the siblings were born, and whether or not they have died. And you can kind of see that there's information contained here that can be used to estimate death rates. And in view of the two challenges I just talked about, this is really good because we can learn about people who we can't directly interview. And we also learn about more than one person from each respondent, which is promising because it means that we kind of get more information on more than one person from each interview, which helps us make good use of our sample size. But there's still some challenges with the sibling survival method. So just to name a few of them, one is that in many surveys, many DHS surveys, for example, we don't learn about enough siblings per interview to produce very precise death rate estimates. So it's a challenge to estimate deaths by age group for a single year, for example, from many DHS samples. There's been a lot of kind of interesting methodological disagreement about how sibling data should be analyzed. And then the sibling method is not really something we think would work well in some specific but important situations. So for example, in the immediate aftermath of a disaster, for a very short time frame, for a very specific geographical area, et cetera, et cetera. So a lot of my work has been kind of asking the question, like, how might we go beyond SIBSHIP, sort of generalize beyond the SIBSHIP method to ask about other types of social relationships? So the way to think about this is the sibling method asks about one particular type of relationship between people, which is to say the SIBSHIP relation. So two people are connected to each other if they are siblings. But you could think of a lot of other ways that people can be connected to each other. So for example, they might be extended kin, they might be neighbors, they might be friends, et cetera, et cetera. And some of my work has produced this kind of statistical framework that I call network reporting, which can be used to figure out how to produce estimated death rates from reports based on any of these relationships. So that kind of shifts the focus towards a practical question, which is, which type of relationship do we think is going to produce the most useful information for estimating death rates? So one thing to think about here is what trade-offs might be involved in picking one of these relationships versus another. And I'm going to kind of talk about how I think about this, or at least how I think about it right now, which is that we're interested in kind of thinking about what the differences are between a relationship like siblings when compared to, say, a less strong relationship, something like people you might know or be connected to through acquaintanceship. And I'm interested in how we might think errors in the estimate will behave as we move from one extreme to another. So it's useful to kind of think about this sociological idea, which is the strength of a relationship, the kind of social tie strength of the relationship. And from that perspective, we can think about what happens to the error in our death rate estimate when we move from asking questions about a strong tie, like siblings, to a relatively weak tie, like acquaintances. And I think there's kind of two important dynamics that are likely to be at play here. One is that we know that strong tie networks tend to be smaller than weak tie networks. So people tend to have many more acquaintances than they do siblings, for example. So that means that the sampling error in the estimate should be lower for these weak tie networks because we get more information from each interview, because each interview produces information about all of the other people in each respondent's network. On the other hand, we think that people will be able to report more accurately about others who they're connected to through strong tie networks as opposed to weak tie networks. So for example, I know a lot more about my brother than I do about a random acquaintance whose name I happen to know and to have had some kind of interaction with in the past year. So that suggests that the non-sampling error in our estimate will be relatively low for the strong tie network and relatively high for the weak tie network. So what we care about at the end of the day is how accurate the estimate is, and the total error of our estimate will be related to the sum of the sampling and the non-sampling error. And so this kind of framework suggests that it's worth thinking about trying different types of relationships on this spectrum, from strong ties like the sibship relation, very weak ties like the acquaintanceship relation, and maybe other possible relationships in between these two. And if we do that, we may build up over time a picture of which types of relationships produce the most accurate death rate estimates. So just in light of the specific empirical example I'm going to talk a little bit today, I'm going to be comparing estimates from the sibling method, which I think of as a pretty strong tie, to estimates from a couple of other types of relationship, one of which is acquaintances, which I think of as a very weak type of tie. So we think that the sibship reports will have relatively low non-sampling error, but pretty high sampling error. This other type of network, I think, will probably have relatively high non-sampling error, but relatively low sampling error. And the question is which of these two produces more accurate estimates. So I think there's a lot of ways we could test these ideas. And so some colleagues and I conducted one survey in Rwanda where we tried two different types of social networks and compared them to the sibling method. So this was on a survey that was nationally representative of Rwanda and intended to mimic a demographic and health survey. And we had about 5,000 Rwandans in our sample, and we randomized respondents to report about one of two different types of social networks. And so each type of network had about 2,500 respondents. So the first type of network we asked people, about half of our sample, to report about was this acquaintance network. And this is essentially people a respondent has had some contact with in the previous 12 months. So how many people do you know who have died in the previous 12 months? And so that's, as I was saying before, what I think of as a very weak type of network connection. We also asked about this meal network, which is intended to be a somewhat stronger, but not super strong type of network connection. And this is people the respondent shared a meal or drink with in the past 12 months. Just to recap, we're going to compare these two methods. The sibling method has the respondent report about their siblings. The network method has respondents report about people in their network, either acquaintances or people who they shared a meal with. We think that there'll be relatively little information per interview from the sibling method and more information per interview from the network method. But we think that sibling responses will be more accurate than responses about the network. So we compared the results of our network survey in Rwanda to a nearly contemporaneous DHS, which asked the sibling history questions. And I won't go into those in detail here because I think probably most of you are familiar with that. But I'm going to present you with a very limited slice of the results. First, I'm going to show you information about the average number of deaths each respondent reported. And so you can see that this is the acquaintance network, the meal network, and then here is sibling deaths over the past 7 years and sibling deaths over the past year. And so you can see that we learned about many more deaths per interview using the two network methods, which is what we would hope. And then we used the reported information about deaths in the networks and among siblings to calculate 45Q15. And you can see here the resulting estimates from the acquaintance network, from the meal network, from the sibling histories, and then from a few different kind of big agencies that produce estimates. You can see that the estimates are pretty similar, especially for males. There's a little bit more variation in the estimates for females, but they're sort of plausible. The network estimates are plausible. We essentially showed that this approach is feasible on a DHS survey, and that we get kind of roughly similar results using the network methods and the sibling method. There's a lot of other stuff underway. I have a paper on using these network reports in the context of an online sample. I'm working on big study in Brazil where we're comparing estimates from 27 cities to vital registration data. And there we can see that the network estimates are pretty competitive with the sibling estimates, at least at the level when samples are small. There's a lot of kind of technical details I haven't had time to talk about. I'd be happy to discuss some in the questions or refer you to some of the papers for those. But including like this framework for sensitivity analysis, which can explain how different types of errors will affect the resulting death rate estimate. Let me just kind of not dwell on these. You can see some of the papers on my website. I'd be happy to answer questions. The big picture idea is if you think that people in a given setting will be able to report reasonably accurately about others who they're connected to through some relationship other than SIBSHIP, then I think we're at the point where we can figure out how to produce good estimates from those reports. And so it's worth trying relationships beyond just SIBSHIP to produce death rate estimates. Great, so happy to take questions, and thanks so much for asking me to join you.
Thank you so much, Dennis, and thanks for staying within the time. I know there is a lot more to share, so I do encourage everybody to go and visit your link so that they can learn more about this interesting experience. I'm sorry, Elena, you're squeezed to the end here. And now we turn to Elena Cruz Castanera, the demographer at the Population Division at the UN Economic Commission for Latin America and Caribbean. And Elena will make a presentation on the use of censuses and surveys to estimate adult mortality. Elena, the floor is yours.
Thank you very much, Francesca. Can you see my presentation?
Yes, we can see and hear you well.
Okay.
Thank you.
Okay, great. So hi, everybody. If you're not convinced yet of the importance of having mortality questions in census and surveys, so I'm here to try to finalize and convince you. No, just kidding, but it's really something very important. Usually when defining census questionnaires and surveys questionnaires, we have all people from different areas, right? Thinking that the question is the most important one and the issue is more important. So I just want to give this overall view. Why is it important? And then, so if you are already convinced that you can use some of these arguments if you want to when you're trying, because our task as demographers, usually we are small in a national statistical office, and it's difficult to get through our point. So overall, the number of deaths, it's used to estimate life expectancy, right? So which is the average number of years a person is like to live if the conditions that exist in the period we are analyzing, estimating life expectancy, continue through their lifetime. So this number, the life expectancy, tells us the level and the level across countries. It's telling us the quality of the healthcare in the country, including vaccinations, the level of economic and social development of these countries, and also the environmental factors. So everything that affects the living, right? The conditions and the health conditions in the society. So the better the healthcare systems, the higher will be the life expectancy. With the COVID pandemic, we see almost every day now in the news the number of deaths and the great demand of the population to know this number of deaths and the impact of the pandemic in the country. So why is that? These numbers are telling us the living, right? The likelihood of dying in the country, city, or neighborhood that we are, and the increase or decrease of this likelihood in time. At the end, it indicates us the gravity of the pandemic and how it's being managed somehow. So if it's getting worse, getting better, what is being done. So and countries that have been able to compile and rapidly process the information have had more resources for developing COVID-19 action plans, and also better tools to track the disease. And if you're not convinced yet, so it's number of deaths by age, sex, and cause of deaths are 12 SDG indicators, at least, because it also influences the population and how we estimate and project the population. So we need the mortality is one of the 3 components of the size of the population. So it's the denominator of almost like for many SDG indicators, right? And also the life expectancy is one of the 3 components of the Human Development Index. So it's clue, right, to tell the situation of living in different countries. So the need of data. We have no doubt CRVS data are the gold standard for the estimation of mortality in countries. Once the capacity to get these data is installed, it is low cost, continuous in time, and can be disaggregated at small territorial levels by cause of deaths and other characteristics. So it's really having a continuous database at the subnational level, informing us. It can, in some countries, it informs like weekly with 1 week delay only about these deaths. However, this gold standard really very good. You can get the data and produce mortality estimates without doing any completeness assessment. It's only 70% of the countries that are the human mortality database countries. So 5 in Asia, 1 in Latin America, 2 in Oceania, 31 in Europe, and 2 in North America. So it's really a small fraction of countries in the world that have this really gold standard top mortality data. And we still, for some countries, we are not even able to get any data from CRVS. So with all the effort of WHO to get data from countries on the number of deaths, even if it's only like small completeness, but to have something, to have the historical series and see how it increased or decreased, only 60% of countries have reported this death into 2020. So we really are missing a big fraction. And well, we still, even with well-function and all that, we have a perfect CRVS system and everything and high completeness. We still, during the pandemic, had some problems to collect the data, right? So the well-functioning system were impacted. We saw with the UNSD webinars where civil registers were interviewed and saying about the situation. It was challenging to get this data. So there is a great need of data to know the recent past and the present. So if we are not in this gold standard top mortality data, what we need to do? So if we have some CRVS data, we do completeness assessment of the data, right? And or if we don't have any CRVS data, we need a lot the census and surveys. And there are countries that are no data at all, so we don't have completeness. So it's very challenging to be a demographer, to estimate, to do population estimates and projections with these countries with no data. So why is it important to have the census? They are very, very helpful. So even if the completeness is more than 60% in the countries, so we can estimate that distribution methods, right? But still they give us a big range of possibilities. So at the subnational level, we have some challenges because of internal migration and also for when it's not intercensal period to measure this completeness is also a big challenge. So having surveys and census that asks about mortality, it's clue and helps a lot, even in the context when we have some CRVS data, but we need to do this completeness assessment. The questions and information from census and survey, they help us with the estimates. So they are very useful in this context. So the way we see it is like having a dark room with the true value inside, and each the CRVS information gives us, when it's incomplete, right, a window to see the value inside. The survey gives us another window. So the more window we have, the better we will know the estimate, what the true value in the middle, okay? So it's very, very helpful. and better will be our estimations. So how they are usually collected in census and surveys, Stephanie already went through this in more detail, so I will just summarize it here very quickly. We have the summary questions on survival of children ever born, parents or siblings. So this is just, is your parent alive? For example, for the parents. But no, it does not ask the complete history, right, with the date of death, because in census there's not much space for that. So how we use this information, we're using directed methods to estimate the mortality and get the mortality based on these questions, right? Also, in surveys, we have the complete birth, siblings, and parental histories. So it's not we collecting surveys and census, and are very useful too. And the
Elena, sorry, 2 minutes. You have 2 minutes left.
Okay. So we have the recent household deaths, right? That has age, sex, and month of year of dying. It's a direct question recommended in the UN. So here are some possibilities of adapting these questions, these classical questions. So we need to expand the reference periods, for example, in the household debt, so you can access it after seeing. And the advantage is that the household question is a well-established question, have the same numerator and denominator. The disaggregation for the mentioned characteristics are more challenging, so it's very useful when you have the same numerator and denominator to estimate mortality. And the question has its pros and cons, right? So we have the selection errors that are expected, already mentioned in the chat. So if a unipersonal household, the person dies, how are we going to, so we know that this problem exists based on the design of the questions. How can we adjust this? So the literature shows that the denominator of you take out the people living in unipersonal households, right? And you assume that the risk of them of dying is the same as one in two households, for example. So, but now it needs to be done carefully. It's not straightforward, right, when you're estimating mortality and using this data, and but it's still very, very, very useful. And this is just a final example of different data sources in Peru to estimate the probability of dying between 50 and 60 years old. And then how, so the completeness assessment, it's this wide estimates here. And here is the sibling history, and here the information on household debt. So you can combine all these estimates in time and see what makes sense and do this assessment analysis and what will be the true level of mortality based on different sources. So that's the message. All data is important, it's useful. Data from health system, data from civil registration system, for surveys, for census. The more we have, the better our estimates will be. Okay, thank you very much for your attention. And I give you Francesca.
Thank you so much, Elena. And again, thanks for staying within the time. Unfortunately, we came to the end of the allotted time for this event. It's 10:30 in our side of the part of the world in the Eastern Standard Time. But allow me, so we won't have time for questions, but allow me to now introduce John Wilmoth, Director of the UN Population Division, and Steve McFeely, Director of Data and Analytics at WHO, for their concluding remarks. Over to you, John.
Thank you, Francesca. I'm sorry that we do not have time for questions and answers from other participants. It's clear that the challenges of estimating mortality were already there before the emergence of COVID-19, and that's due to the slow pace of development of CRVS systems in many regions. And so we've seen in the presentations from Richard and Elena in particular, they've showed us some of the ways that mortality data collected in censuses and surveys have been used in national and regional settings. But all the challenges of estimating mortality that were there before, they were compounded during the COVID pandemic, due both to the elevated number of deaths and to the difficulties of collecting data during the pandemic. We heard some ways to address this in the presentations from Stefan and from the colleagues from Bangladesh. A key conclusion concerns the need to modify questions that are asked about deaths in censuses or surveys to better capture the deaths and the information that we need about deaths from COVID, including greater detail about the timing of deaths. We could also look, as we heard from Dennis, at innovative approaches for expanding the universe from which adult mortality is being estimated. So moving forward, Working Group 2 will work toward elaborating a set of recommendations on how best to utilize censuses and surveys to collect adult mortality data, benefiting from lessons learned during the pandemic. And UN-DESA will convene an expert group meeting later this year to develop these recommendations. In the absence of complete civil registration data, we have to accept that no alternative source can give us a complete picture of the levels and trends of mortality in a population, including for deaths associated with the COVID-19 pandemic. These approaches are being assessed by the approaches that are being assessed by the working group may offer a cost-effective way to gain additional information on mortality within censuses and surveys that are already being planned. So in closing, I wish to thank all participants for your contributions today and for your continued involvement in the work of Working Group 2. And now I will turn the floor over to Steve McFeely, Director of Data and Analytics at the World Health Organization, our collaborators in the Technical Advisory Group. Steve will offer a few remarks to bring this event to a close. Over to you, Steve.
Thank you, John. Thank you, Francesca, and hello to everybody. Good morning, good evening, good afternoon. So just to add to what's been said, in December 2019, COVID-19 unleashed chaos. And when it came, we were not ready. Certainly statistically, we weren't ready. NSOs and international organizations around the world were forced to adapt quickly to the challenges of containment. And as we heard, many surveys were interrupted. And unfortunately, COVID-19 collided with the traditional census year, leading to many vitally important censuses being postponed. From a statistics perspective, a very important question emerged very quickly. How many people were dying of COVID-19? A straightforward question, perhaps, but one that was incredibly difficult to answer. So apart from the normal definitional issues that would arise with any new phenomenon, we had a much more basic or fundamental problem, and that is we don't really know with any certainty how many people die or of what cause in a normal or routine year, let alone during a global crisis. The WHO score assessment suggests that about 40% of the world's deaths go unregistered, and registrations can be as low as 10% in sub-Saharan Africa. And an assessment of the SDG indicator 17.19.2 using the UN Global SDG platform reveals broadly similar conclusions. So as of this morning, the WHO is reporting that 5.7 million deaths have been attributed directly to COVID-19. But we know this is an underestimation. Various academic studies and our own estimates of excess mortality, which will be published in March, suggest that excess mortality associated with COVID-19, either directly or indirectly, is more than twice that number. So as we've heard today, surveys and census contribute valuable pieces to this complex jigsaw puzzle, especially where mortality registration data are unavailable. We've also heard why these data are so important, but I would like to suggest that they are no substitute for a robust CRVS, and CRVS remain the bedrock of mortality statistics. But in the short term, we've been forced to use a wide variety of sources. But it is incredible that more than 20 years into the 21st century, the basic CRVS are not commonplace everywhere. At the very least, births and deaths should be registered even if cause of death remains unclear. As the saying goes, never waste a crisis. COVID-19 should have provided the wake-up call that we all need to understand the importance of robust CRVS. And this is a key lesson that I hope we will learn. Unfortunately, already we see indications that in some countries have not learned this lesson, choosing to remain in denial, claiming that they have high-quality registration systems, when self-evidently they do not. I genuinely hope this is a short-term myopia and the lessons that we can learn together so that we can develop the infrastructure we need to prepare for the next crisis. Furthermore, countries that claim that they have good quality data should share it. In a time of global crisis, these data should be considered global public goods. In conclusion, I would like to thank the Technical Advisory Group on behalf of the WHO, on behalf of UN-DESA, for their extraordinary contribution during this extraordinary time. They've done an amazing job. On behalf of everybody, I would like to thank them. Thank you. Back to you, Francesca.
Thank you, Steve. And with that, the event is concluded. And I wish you all a great day. And thanks again to all the panelists, all the participants, and everybody who was with us and contributed in the chat with their inputs, their questions. We'll take the questions and put some answers on our website so that we can continue this conversation. And sorry, there was not enough time to address all the questions during the event today. You all have a great rest of the day and the evening, wherever you are. Thank you.
Thank you.